Good afternoon. Coming to the sometimes bad side of tumor development. I will try to convince you that SNParrays can help to discriminate and to identify tumors. I don't want to go into details you have seen. We are using the CytoScan array since more than a year, and I'm really happy to have this tool in hand. You have also seen the chess, the software to analyze the data. This is a karyotype. I'm not sure you're used to it. This is R-bending, which we preferred at these days because it preferentially identifies the tips, and the tips, you know, are most likely lost in tumor cells. Now, you see a 1p deletion, which is very frequent, especially in pediatric tumors, but also in adult tumors. You see something happening on chromosome 2. There's something in addition. On 3, there's also something going on. On 9p, there's definitely a loss. On 17, there's a loss. Maybe there's a marker we identified as a 17. Also, this was identified as a 17. But that's it. Yeah, you will ask why not staying with karyotyping. It's nice. It's a little bit laborious, but I tell you, this karyotype is 1 out of 100 or maybe less. It is virtually impossible to get on a routine basis chromosomes out of a tumor. It's the same tumor now with chess or with a CytoScan. Of course, we see all aberrations which we have seen here, but we see, of course, much more. We see, for example, these 2 peaks on chromosome 2, and if you zoom in, then you identify one as an NMIC oncogene. This is this peak, but there's another peak. They actually, altogether, there are 4 peaks, and this was quite surprising because the other one is an ALK oncogene. And I'm not sure if you're aware, we already use in phase 1 and phase 2 studies ALK inhibitors. So it's essential to know to whether or not this tumor has an amplification or a deletion or aberration in this oncogene. So we gained a lot more information. Before we only have seen double minors, but that's it. We could only guess which genes are included. So, neuroblastoma, it is not a CNS tumor. It's from the peripheral nervous system. It's a strange tumor because it has a very high rate of regression, spontaneous regression, especially below 18 months, has a high rate of spontaneous maturation above an age of 20, 24 months. And approximately 60% of the tumors have a very aggressive and tumor growth. And before we knew about the genomic alterations, all these 3 types have been treated in the same way because we could not discriminate a regressing, a maturing, or a progressing or a very aggressive tumor. According to the staging, we have localized L1 and L2, and from the metastatic, we have M and MS. So believe it or not, this tumors is MS is a very special type. It disseminates to the liver, skin, and other areas in the organism, but it can spontaneously disappear. The doctors don't do anything, they just watch. So just to give you an impression what we always do, we still do fish for the NMIC, but of course we use an array on every tumor. But now a historical Kaplan-Meier curve, I'm pretty sure you know. These are so-called survival curves. They give a probability of survival in a different age period, so it's always 10 years. And if you see here, especially the stage 3, so a localized disease, or the stage 2B, this blue line, they drop down to 15% or 70%. Very, very bad outcome rates. This is stage 4. This is also not brilliant, not at all brilliant, but approximately 23%. And the next study, 1994, it changed drastically. So the localized diseases up here are really in the more than 80% long-term surviving. What is the difference between these two studies? Actually, we introduced one genomic marker, that was NMIC, to discriminate aggressive from less aggressive. And what we did, or the clinicians, I'm not a clinician, they reduced treatment in many, many instances, and for the non-amplified tumors, and the amplified tumors received much higher therapy. So this is a result of the first genetic marker introduced in the clinical decision-making process. This is now a classification. I had the honor to work with this group. It's an international group of Australian, Americans, Japanese, and Europeans. And we gathered together 8,800 neuroblastomas. This is quite a lot for pediatric tumors. And we have seen that amplification really changes the outcome drastically. In the localized stages, you always see here, not amplified, very low risk, amplified, high risk. And that's going all the way through all stages. If you have an amplified tumors, it is an aggressive one you have to treat, independent of age and stage. I'm not sure if I, as a matter of time, I can go into this. What we realized, amplification is not always amplification. It may affect only a part of the tumor cells. In this case, only these 3 cells amplified. All other tumor cells are not amplified. This is tumor heterogeneity. And this is one tumor where we have received a large piece of tumor, where we have been able to look at 4 different sites. And actually, in only one part of it, we found the amplification. And in all other 3 areas, we did not find the amplification. This is a background which we found. We have analyzed more than 20 NMIC heterogeneous tumors so far. We find no segmental aberration, we find segmental aberration, and we find a recently described cytogenetic event, which is called chromotripsis. I will go into this a little bit later. The next markers we introduced into this worldwide pre-treatment classification schema was an aberration on the long arm of chromosome 11. Though this was also indicating if there is a deletion of the long arm of chromosome 11, these patients do bad, and they have to be treated differently to those which have no deletion. This is for these 2 groups, is localized, and also for these so-called MS tumors. How does this look in the CytoScan? This is 11 co-deletion in red. There's actually a gain of the short arm and part of the long arm of chromosome 11. This is clearly deleted. And this chromosome 70, the long arm, is gained. So it's a non-reciprocal translocation between 11 and 17. These are whole chromosome gains of chromosome 7 and 13. Here you see clearly a complete loss of heterozygosity, and you see that drop between 2 copies and, no, actually between 3 copies and 1 copy. So this is trisomic, as you see here, and this is monosomic. it's hard to see. This patient actually had a UPD. This is peripheral blood, a UPD, interstitial UPD, and acquired an 11q deletion actually in the UPD region. Therefore, I asked the speaker before if he finds an association between UPDs and segmental aberrations, what we call. I think this is not it's an unexplored area. Okay, I bring you to the current European neuroblastoma study, which actually introduces now these so-called segmental chromosomal aberrations, as I've shown you with 11q deletion in the decision-making process. So this is again this MS, this special metastatic form. And if there are no life-threatening symptoms, then there's a clear discrimination between tumors without segmental aberrations and tumors with segmental aberrations. These tumors get a treatment, a chemotherapy, whereas these patients don't get chemo. So it's a clear decision-making process, and it's now running in Europe currently in 7 countries. I need to say that all these data are centrally reviewed. So we have an online reviewing system because, of course, these are very essential decisions for the child. So we decided to have all data reviewed. And finally, I'm responsible for all this. Okay, I'll bring you a little bit to the future. Oops, sorry. Recently, there was a description of a deletion syndrome or a deletion in the so-called ETRX gene, which is believed to be a prognostic marker, at least in the presentation presented last year. They have shown that specifically elder patients, older patients have this deletion, that they have a very peculiar clinical course. And there's another paper also published last year about chromotripsis in neuroblastoma. I will show you a little bit later about this very peculiar situation. This is from a review of Peter Campbell and Philip Steffens, showing the hypothetical generation of this chromotripsis, which is the chromosomes breaks into hundreds of parts and rejoins again. And this results in this very peculiar situations where you see there are 2 amplifications, but all these up and downs, this oscillation of a 2-copy and a 1-copy state is a clear indication of this chromotripsis. So there, I counted here 109 breakpoints, quite a bit on one chromosome. The rest of the genome is completely untouched. It's only one chromosome or part of a chromosome really split into these 3 fragments. I give you some other examples. It's hard to see, but here you can clearly see this up and down, this modulation or this oscillation of the copy number within one chromosome. Here it's chromosome 16. This is a germline, but this is a tumor. And also here it's more interesting, but I think that's, yeah, it skips this. I will only give you a few examples that we also use it for diagnostic purposes. Here in the case of the rhabdoid tumor, this is associated with a deletion of the SMARCB1 gene, which is on chromosome 22. And here you clearly see this deletion here in this region. This is a gene of interest. Here it's a blow up. This is exactly the region where the deletion happened. And nephroblastomas, or other known under Wilms tumors, where this tumor is frequently associated with a deletion of the WT1 gene, WT1 gene. And here is a homozygous deletion of this gene. And another nephroblastoma with a deletion of the whole arm of chromosome 17, resulting in loss of p53 function. I hope I could convince you that SNParrays are helpful to decide the appropriate diagnosis, and also importantly to find or to give very accurate information to the treating physician about the outcome of this patient. And last but not least, the group I'm working with, Reza, is doing a lot of bone marrow analysis, so we can also isolate tumor cells from the bone marrow, and doing SNParrays, looking for the development of the tumor cells. Clemens he's not on this picture, unfortunately. He's doing the lab work. And last but not least, my wife. She is helping a lot with the interpretation of the data, which is not quite so easy. Yeah, and thank you for attention.